So hello everyone. I hope you can hear me well. I just switched the sound device because I got a message that it's not so good. So I hope it's better now. Again, please send us a chat. We are monitoring the chat if there are any technical problems at any time. Good evening, everyone. I think it's time to start. 4 minutes past the starting time, and my task is just to give you a short introduction. I'm Axel Glasmacher. I'm the treasurer of the Cancer Drug Development Forum, who is hosting this webinar. So let's first have a look at who we are. The CDDF is a non-profit organization based in Brussels in Belgium, and it strives to provide a platform to all stakeholders to accelerate the delivery of effective oncology agents to patients. That means that we bring people from academia, the pharmaceutical industry, regulatory authorities, health technology assessors, and very important patient advocates together. If you want to know more about it, please go to our website, cddf.org. This meeting is also co-sponsored by Catenion, who are a Berlin-based consultancy focused on pharmaceutical portfolios and development. We have a few technical aspects, so you are all put on mute to preserve good audio quality. Please use the chat function to report any technical problems. Questions can be asked at any time using the Q&A function. I see the people are doing that already. It's very good. And we will address the questions afterwards. And our expert, Professor von Lienfeld-Thurl, will answer them. Please note that the session will be recorded, and the recording will be available tomorrow on the website of the CDDF. We have a rule that applies to all meetings of the CDDF, the so-called Chatham House rule. So when a meeting is held under that rule, all participants are free to use the information received, but they are not free to reveal the identity or affiliation of the speaker. So that's what we do. You are very welcome to use social media to inform about this meeting, but again, then refer to the meeting overall and not to individual questions or statements. That is, if you need a quote from our presenter, please ask her for her agreement. So that brings me to today's agenda. You are already nearly through the introduction. Then we will hear Professor von Lienfeld-Thurl, and then the Q&A period starts. That will be co-moderated by my colleague, Professor Jaap Verwey, who is the General Manager of the CDDF, and we will alternate to bring your questions to Professor von Lienfeld-Thurl. She is a professor of medicine at the University Clinic of Jena in Germany, with a focus on hematological malignancies and on infectious diseases in immunocompromised hosts, especially virology. And in this context here today, she is an expert because she is the lead author of the German, Austrian, Swiss guidelines for COVID-19, as well as for the EHA, European Hematology Association, Scientific Working Group on Infections in Hematology recommendation. And again, the links to these documents can be found on our homepage. Of course, the German, Austrian, and Swiss guidelines are in German. So that is restricted to German speakers. So Marie, I'll turn it over to you, and please start.
Thank you very much. I hope everybody can hear me well, and I'm looking forward to finding my slides, which are hopefully here. So it is a pleasure for me to share with you some information on SARS-CoV2 in hematology and oncology. And as Axel kindly introduced myself, I think I'll just start and get going. I'm afraid this slide is in German, but it really is my conflict of interest. So I did get some money from people. Let me start by defining what SARS-CoV-2 actually is. It's an RNA virus, beta coronavirus to be exact, and it belongs to the community-acquired respiratory viruses, which we abbreviate CARV. Now, the most prominent CARV definitely is influenza, but also CARVs like parainfluenza or RSV or human metapneumovirus actually play a role in cancer patients. And we know many coronaviruses which also play a role. And maybe most prominently, SARS coronavirus some years ago actually caused a severe disease which somehow disappeared in the frequency. But SARS-CoV-2 occurred in China at the end of 2019 and was first observed there and described. And SARS-CoV-2 is named like that because it is similar to the original SARS virus and causes a similar disease, but it's the second coronavirus which does that. So this is the name of the virus. And COVID-19, which you will have heard a lot, is the coronavirus infectious disease, which is the name of the disease in that situation. Now we do that in CARV infections. So we name the respiratory tract infectious disease and abbreviate it with it in the end. And we divide it into upper respiratory tract infectious disease, which is really what you know as the common cold. So you would be suffering of cough and sore throat and things like that, and just feel quite unwell. And then to be true, it is a viral respiratory tract infection. The virus needs to be confirmed by nucleic acid testing. Ideally, PCR is what usually is used. Now, if it goes down to the lung, we call it a lower respiratory tract infectious disease, and we define that by typical symptoms of bronchitis and dyspnea and declined oxygen saturation or bilateral ground glass infiltrates on CT. And let me just say that CT really is the way you diagnose the pneumonia in those virus infections, at least in cancer patients. And you do that for all CARVs, but especially for SARS-CoV-2. And especially with SARS-CoV-2, there's a risk that may progress to respiratory failure. Now, SARS-CoV-2 infections, we now know, are also typically associated with somehow strange symptoms like a disturbance in taste or myalgia and more atypical symptoms, although most patients do present with cough and fever. Now, the clinical course is a little different from what we know from other CARVs, like, for instance, influenza. We all know that. You get ill very quickly and you have a high fever, and then you're ill for a couple of days, but you get better within a week or so. Now, with SARS-CoV-2 infection, it's actually different. So it starts with a fever and cough typically, and they progress rather slowly, and it really gets bad only in the second week, where dyspnea might turn up and you might actually become critically ill. Obviously, not all people do that, and quite a few actually stay oligosymptomatic or asymptomatic. But if there is a severe course, this is sort of a typical severe course. And what happens when you actually have that severe course in that second week? Now, there is a high grade of inflammation, and markers of inflammation like ferritin or IL-6 will be high, and they will be higher in the non-survivors than in the survivors, as you can see here, and IL-6 prominently as well. So there's a hypothesis that the clinical course of SARS-CoV-2 infection actually goes through 3 stages, and you can see them here, and I apologize for the quality of the graph, which has been massively improved by the work of Axel, which you can see here. But it really depicts that in the first stage, it's the virus which replicates. This is when you actually have high viral loads in swabs or wherever. And it is the early stage where probably antiviral drugs may work if they do. Then it goes down to the lung and you have a pulmonary phase, and that is actually then evolves into a hyperinflammation phase with all those elevated inflammatory markers, as I just showed you. And here actually other drugs might play a role. So this hyperinflammation phase is actually like a cytokine storm, or may mimic a large degree of vasculitis thrombosis as a clinical problem. And of course, you could consider immunosuppression as treatment of that. Now, let's just first discuss what the risk factors for a severe course like that might be. And it is what we know from SARS-CoV2 infection, advanced age, hypertension, and diabetes, possibly male age, and there might be this, that, and the other. Maybe asthma plays a role. I think there's still a lot of questions to be asked and answered. We think cancer patients have a worse prognosis, but we're not definitely sure about that yet. But we know that cancer patients are prone to more bacterial and or fungal superinfections, and that definitely is worse for the outcome. If you talk to people from Italy, they say in personal communication that maybe the mortality in hematological patients might be around 20%. That needs to be confirmed, but that is sort of a figure which has been mentioned before. Now, what is out there on published data on COVID-19 and cancer? It's really 2 publications, and it's small numbers. This is the earlier one, and it's only 18 patients of more than 1,500 hospitalized COVID-19 cases. And we know very little about the cancer disease. So lung cancer seems to be the most frequent type, and only very few actually had received chemotherapy or surgery immediately before that. Most of them were long-term survivors. And compared with the patients without cancer, the cancer patients were older, more likely to smoke, had more polyemia, and had a more severe baseline CT. And really, it's not surprising that this population might actually do worse than the rest. So I think it's a little difficult to quote that figure if you consider that they actually have many risk factors, which we know from other data as well. This is a slightly larger population, which has been published just recently, 28 patients only with solid tumors hospitalized in China. Again, more men, similar median age. Again, more lung cancer as most prominent tumor. And what's interesting is that 8, that is a third, actually acquired the infection within the hospital. And I think that's a very important point, and that is an observation that has been made in the hotspots, that really the hospital is a very dangerous place to be in. And I will comment on that later as well. Now, the symptoms were as you might expect them to be, but what I found interesting also in the lab results is that many patients presented with hypoproteinemia, suggesting malnourishment. And maybe that is also something that is associated with a worse outcome, since many of them actually became critically ill. But what they found on multivariate analysis are 2 risk factors. So they found that a very patchy CT scan was associated with a worse outcome. And this is an example of what CT scans can actually look like in these patients. And the other risk factor was whether they had received anti-cancer therapy more or less immediately beforehand, or whether it had been more than 2 weeks ago. So if it had been more than 2 weeks ago, obviously the outcome was a little better. And I think that is also important information. So what do we recommend our patients to try to help them to prevent COVID-19? We recommend strict adherence to the general contact precautions, and that really differs from country to country, but we focus on hand hygiene and think that is really very important, and on social distancing or social isolation. And obviously symptomatic families should really be stay away from the cancer patients. We offer face masks, but that is a bit of a problem because they might give a false sense of security. And it depends on the face mask, what it actually does, whether it protects the person who carries it or the rest of the world. So that needs a bit of education as well. And we try to focus more on social isolation and hand hygiene, really. But also, as I may have showed you before about the malnutrition, so we think good general health should be reinforced and people should eat enough and be healthy, do physiotherapy, and not have any vitamin deficiency or anything like that. To improve their health as well and make them less susceptible to infections in general, we recommend intravenous immunoglobulins, but as they're recommended by EMA, not in any other indication. And most importantly, nowadays, intravenous immunoglobulins obviously don't have any specific antibodies against SARS-CoV2, so they don't work against that, but they might help to prevent any other super infections, for example. We give a rather strong recommendation not to implement additional antimicrobial prophylaxis regarding antibiotics and also regarding GCSF, because that might actually worsen lung complications. And we give a recommendation to be vaccinated properly, as we recommend anyway. So basically seasonal influenza and pneumococci are the ones to cover. Now, organizational aspects, if we take all of this seriously, it also means that we need to restructure everyday care. We need to spend time to educate patients, and that really is a considerable factor. So patients have lots of questions and they take up more time than usually. And as I said, we actually, in my practice, we do recommend all patients under active cancer therapy to practice social isolation. And I think cancer patients are very willing to do that. But that doesn't mean just telling them, but it also means that we need to restructure our waiting areas. We try to reduce patient contact as much as possible, but sometimes really the patient has to come to a specific lab, and we try to respect that and then find a solution how we can still reduce contact. We need dedicated areas, and I think that's something how hospitals have to be managed, but that also might mean that the whole organization of the hospital is different than people are used to. So people have to get used to the different circumstances. And obviously we need enough personal protective equipment, because as I said, really spread within hospitals is a real problem. And also staff becoming infected really also is a very, very big problem. And somehow it's shocking that this seems to be a problem to provide that equipment, but that's how it is. So we have to cope with the challenges due to a massively changed work environment. And we in Germany are still lucky, but there's expected to be a significant rate of infected caregivers in Germany as well. And there already is in Italy and Spain, and probably in the US. But our aim is to absolutely ensure that appropriate cancer therapy can be given. And therefore we have to take that into account and do many organizational changes. Like, for example, we have to discuss whether a patient can actually get the therapy the patient needs, or if we might have to defer it. And in the EHA recommendations, we came up with this flow chart, trying to help people to decide whether somebody, for example, a patient with active malignant disease, should get therapy, yes or no, conventional therapy, that is usually. And so if the patient has no symptoms of respiratory tract infection, then we ask, is there high risk for them to actually be asymptomatic? And if there's not, then we recommend to carry on as you would usually. If there's a high risk that the patient is asymptomatic, then we again reinforce the contact isolation and but recommend to treat as clinically indicated. Possibly you might try to choose the least immunosuppressive therapy that is available in that situation. Now, if the patient does have symptoms and has active malignant disease, that really is a problem, because you would really like to treat that active malignant disease, but it probably or possibly makes the SARS-CoV2 infection worse. So we recommend, but this is obviously a very difficult decision, to look whether the symptoms of the infection are mild, and then you might try to reevaluate after approximately one week and then decide to provide cancer therapy if the patient is actually getting better. Now, if already here there's a lower respiratory tract infection, that's a real problem, and then really you are in the situation of very individual decisions, trying to understand what's most important clinically here. It's maybe with controlled malignant disease because there's obviously more time. So again, if there's no symptoms of respiratory tract infection, really you should go on with the therapy, and you might consider maybe deferring a little bit to ensure strict contact isolation if there's a higher risk. But really, usually that should just go on. If there are symptoms, it's also easier because the patient has a controlled malignancy. And then we decided the next thing to ask is, what's the therapy interval? So if you have an intermittent therapy, which you give, say, every 3 weeks or every 4 weeks, we think it's probably safe to omit one course and just skip it until the infection has resolved. Now, if it is continuous, that is much more difficult to answer because there are probably drugs which you would stop and discontinue, or there are drugs which you might actually still continue for different reasons. But this is really without any data whatsoever. Now, that is regarding what we do with the chemotherapy or the cancer therapy. How about the therapy of the COVID infection? Now, there's no antiviral prophylaxis whatsoever, and we all know there's no vaccination yet either. So you can't really do anything prophylactically in that sense. But when there is an infection, you can give antivirals. And as I said before, they need to be given early. The ones which are commonly given are hydroxychloroquine. And some people say that if you add that antibiotic, the decrease in viral load actually goes faster and is more pronounced. If that is really true, I think it's a matter of debate. Another antiviral is remdesivir, which is not as available and not as widely spread, but there are actually clinical trials going on. And then there was much hope in the antiretrovirals, like for instance, the combination of lopinavir and ritonavir, which we know from HIV medicine. So it was actually a nice drug because people had experience with it and felt comfortable to use it, at least in Germany. But people were a little bit disheartened because the first randomized trial came back negative, and I'll show you in a minute. But overall, for hematologists and oncologists, it's really important to establish a very close collaboration with infectious disease specialists, because we need them to tell us what is the indication of therapy in an individual patient, when should we start which therapy, and what's actually currently available and being discussed as useful, because that seems to change every week or so. So this is the prospective trial, which came back with a negative result. And you can see that there's tiny improvement by the application of the antiretroviral drug. And if I were to criticize the trial, if you like, you could argue that actually the drug was given very late. So it was a median of 13 days after onset of symptoms. And it was definitely underpowered to show a significance of that possible effect. So I think that is not entirely clear yet. The other area, obviously, of therapy would be the area of immunosuppression. So obvious candidates would be steroids or inhibition of cytokines, like, for example, anti-IL-6 or anti-IL-1, or JAK inhibition, for example. But again, this needs to be decided in an individual center. What is our approach towards immunosuppression? And we need the infectious disease specialists to tell us what might be most useful when. But now, what is the data on immunosuppression in treating COVID? This is an example of tocilizumab, which is an anti-IL-6 antibody used in cytokine release syndrome, approved for that, and it is used in that dose or dosage. And given intravenously. And here's an experience of 21 patients with lung disease due to SARS-CoV2. And you can see that after the application of tocilizumab, they actually improved. So they improved clinically, but also with regard to oxygen need. Excuse me. The other topic would be steroids. And I need to tell you that actually all the people who are interested in respiratory viruses don't like steroids, because steroids tend to prolong the disease, and they tend to prolong viral shedding, and they really are more or less a little bit of a no-go in situations like influenza and pneumonia. So the WHO in the first recommendations specifically said don't use steroids. But then this study came out, and it is a retrospective study looking at 84 patients with SARS-CoV2 lung manifestation. And you can see that the group which did receive steroids actually did better. And that was true in multivariate analysis as a risk factor. So I think we might rethink, and I know that quite a few, for example, Italian centers actually use steroids regularly in that low dose, which is usually used in ARDS. What other supportive therapy needs to be given? We need to supply enough oxygen, and need to discuss the ventilation treatment with the intensivists. What I found important also is to point out that there needs to be some anticoagulation, because we understand more and more that there's an important factor of, or component of, vasculitis and thrombosis in the pathophysiology. We need to be very aware of superinfections. I think some countries seem to treat empirically with antibiotics. We tend not to do that, because we think, well, first of all, we don't know how long we will be having all these antibiotics, so we shouldn't be too generous with them. And also, there might actually be harm coming from that. So it's important to diagnose the superinfection if it is there, and then treat it if it is there, but probably not just prophylactically. And really good news is that in all that COVID crisis, there's so many clinical trials coming up. So we do recommend, if you can, include your patient in a clinical trial. And also as a little note, it's amazing how many regulatory authorities were actually very, very uncomplicated, and trials got registered very easily, and that is very helpful, we think. This is a map of Europe, and because I'm in Germany, this is sort of our map. So we have 7 ongoing, and I know there will be a lot more, because I know that they are being registered. And that brings me to my last slide. And I've been thinking about what there could be to say about clinical trials for cancer in the era of COVID-19. And in my hematology practice, I specialize in multiple myeloma, and I'm a primary investigator in a couple of trials, and I treat many patients in clinical trials. And what I somehow forgot to show you is that one of the most important things we believe to prevent severe infections in cancer patients is also the control of the disease, because we know that patients with controlled cancer are much less likely to have infections or have severe infections. So really, to still provide the best possible cancer therapy, that is of utmost importance to us. And we also know that patients in clinical trials do better than those outside clinical trials for a variety of reasons. That's absolutely clear. But still, on the whole, they benefit from it, and they benefit from participating in trials. So really, I think we have to go on. I think we should go on doing clinical trials for cancer nonetheless, and do it as much as possible. Now, obviously, that isn't all that easy, because there are lots of organizational changes, and a couple of things I sort of came up with is that it would probably be very helpful if the study conduct could be more flexible. So, as I said, we try to reduce contacts. So, a reduction of visits where possible could be a good idea. Also, what I noticed, actually, what I did during the past couple of weeks is that if I had the patient in the, I don't know how many visit, and I needed to do a physical examination as per protocol, and I examined the patient, I don't know how many times before, and there was just nothing to be expected. I actually omitted that physical examination because it is a risk for the patient and for myself, because we become very close. So I think that could be another helpful thing. And if you, I'm sure there are lots of little pieces like that which might actually help. Also, because we try to somehow avoid too much contact, and because maybe at some point university hospitals may actually be short of staff, and also because maybe we might run into problems with investigators actually being ill themselves, it might be a good idea to find a way to be a little more lenient with regard to who is allowed to perform study tasks, and maybe, for example, allow GPs to do more than they do at the moment. That could be one of the thoughts I have. And also I realized that due to all sorts of things, we produce lots of deviations from study protocol, maybe because some diagnostic procedures can't be done because they are considered elective, so they're just cancelled by principle or things like that. So we deviate from the study protocol because we can't help it. And it might be helpful to reduce the paperwork associated with that. Like, for example, possibly by defining what is absolutely vital in terms of procedures. And then we can reduce the documentation of deviations to a minimum, because it also just somehow adds to the workload we have. And the last point I came up with, which might help, is to consider reducing the translational aspects of a clinical trial. So many clinical trials have associated translational trials, and maybe they can be somehow skipped, or something can be done about that, because that often also means additional procedures or visits. So these are my thoughts, and hereby I thank you very much for your attention, and I hope I didn't talk too fast and you could still hear me well. Thank you.
Thank you very much, Marie. I think that went very well. And if you're ready, let's go into the questions already. We already have a nice number of questions. And the first one is about, is it true that cancer outpatients are postponed for their treatment in the UK and Austria? What about patients in trials?
Well, I'm really sorry. I don't know everything about other countries in UK and Austria. I'm afraid it might actually be true, and I think that is a problem. And sometimes I think there might be situations in hospitals and hotspots and countries where you can't help it because the priority really is completely somewhere else. And then I think that is just a disastrous situation. But we are really trying to prepare ourselves well to ensure that that does not happen. But it takes a lot of preparation. And as I said, we are lucky because we're sort of slowly hit. We're not at the end yet. Maybe it becomes a disaster in Germany too, but it is much slower. So I'm afraid probably in other countries that is a problem. Yeah.
It seems we are all on the same trajectory, just at different times.
Mm.
The next question comes from
Julia. There's another question. The question here is that it's possible to differentiate COVID-19 lung disease from drug-induced interstitial lung disease.
I didn't quite get your question because of the internet connection. Was it whether it is possible to differentiate COVID-19 from drug-induced pneumonitis? Is that the question?
Yeah, interstitial lung disease.
Yes. I don't think we have any data on that yet, because I have not read a case report or anything like that on that topic. But personally, for me, that would be well, I would suspect that that might be a real problem, and that it might not be possible to differentiate that. And personally, for me, that would be one of the reasons to be very careful with checkpoint inhibitors or any other drugs which have pneumonitis as a side effect. And I think some other experts actually share that view. So it is a problem, but I don't know of any case reports as yet.
Thank you. The next question was about diabetes mellitus. Is it known whether type 2 or type 1 have a higher risk?
I don't know. I don't know that any of the studies which gave diabetes as a comorbidity actually made actually differentiated. I did not see that anywhere. But in contrast, diabetes comes up always. So I'm sorry. I don't think we know.
Thanks. Yep.
Okay. Yeah. Can you hear me? The next question is on chloroquine. There are. Maybe you should ask the question then, Axel.
Yeah, I'm sorry. Your connection has trouble. So the question is on the utility of chloroquine for treatment or prophylaxis. What is the proposed mechanism of action, and do you recommend it for cancer patients?
It's not recommended for prophylaxis at all. Nothing is recommended for prophylaxis. I'm not sure we know what the mechanism, the antiviral is. It does that in vitro. It is usually a malaria drug, but it works against viruses as well. And we do recommend it for cancer patients. Yes, absolutely. You need to be aware of QT prolongation. So you need to be aware of possible interactions, and that is more relevant in cancer patients, obviously. And that might actually be one of the reasons why you might actually discontinue a continuous drug a cancer patient might be on, especially if you combine it with the antibiotic azithromycin, which is a horrible word. So I think these are the points to make.
There is a second kind of follow-up question regarding this. So you've already answered the prophylaxis part, and the question is whether you would even give it for mild symptoms in a COVID-19 diseased cancer patients, and how would you handle this in the context of a clinical trial? Do you see any impact on the integrity and validity of the clinical trial?
Well, to first answer the easy part, which is the first bit, obviously that depends on your strategy in the hospital. In our hospital, we treat very early, very quickly, and we treat patients who have confirmed SARS-CoV2 infection, even if they have relatively mild symptoms, if they have risk factors like older age. And certainly cancer would be one of the risk factors. So we would treat them. Does that impact the clinical trial? It probably depends what the clinical trial is about and which drug it is. So if it is a drug which we think that might actually interact and might cause problems, then it would impact the clinical trial. But then again, any ICU situation would impact the clinical trial.
Yeah, thank you. The follow-up question here, or another question around this, quotes the European Medicines Agency, who has approved chloroquine and hydroxychloroquine for clinical trials that focus on the use of the drugs and for emergency use programs. So the question here is, what do you think? Should we use it before the end of CT, which probably means chemotherapy? And I think that goes again towards the question prophylaxis in cancer patients.
Yeah, no, but I don't think we have any rationale to give a drug as prophylaxis. I think we should do everything to prevent the patient to get the infection. but I don't think there's a reasonable, I think even it might be more harmful, because it's not just a little drug. It does have side effects. So I don't think that's a good idea.
And we also, of course, have shortages of the drug for patients for whom it's actually approved and effective. Very good. Next question is a different topic. Is there a possibility to identify criteria for pre, during, and post-COVID-19 phase? The question doesn't say more. My understanding is that is for the individual patient, for stages in his disease and the cancer treatment. If that's not right, please send us a follow-up. That's how I understand your question. Marie, please go ahead.
So the pre-COVID, I tried to address in the algorithms. So if you have a higher risk, I consider you as pre-COVID, and then you should do everything to not get COVID, and then carry on. Post-COVID is very interesting. For reasons I don't quite understand, the EBMT gives a very general recommendation not to proceed with allotransplant for another 3 months. And I think 3 months is really long. I know, or I've heard, and that's what people say, and that's also the experience, that some people who get ill with COVID do take long to recover. So it's not that easy. But 3 months, I don't know. So I think really well and virus-free, and then you carry on, and that's sort of the post-COVID recommendation for the individual patient.
Next question is here about a guidance in Germany for remote monitoring per computer camera. And do you have any experience with that, using that for clinical trials?
For clinical trials.
Or other contexts, probably, just as well.
Yeah, no, there are lots of little startups coming up and saying, let's try that and make it possible, and so on. I think many hospitals, including ours, have a problem with the firewall, so we can't actually, at the moment, we can't do it. We have many technical problems with telemedicine, and like, for example, now I'm actually at home because our hospital doesn't allow a proper connection to this conference. So the experience is limited in the university hospitals, and I think probably many have these problems. But
so companies, sorry, please go on.
Attempts to solve that, and there are many people trying to bring tools into practice which might be helpful.
So companies that would like you to use more telemedicine approaches for monitoring of patients in their trials should also offer the right technical solutions for that.
I'm afraid so, yes.
And Jaap, who is practicing in the Netherlands, just sent me that Dutch general practitioners are now using telemedicine as a standard. And it's made possible from last week. And yeah, here also in the treatment of normal statutory health insured patients, telemedicine has been set up from a point of administrative procedures as having the same importance as a face-to-face visit. So let's go to the next question. We have a few questions about methylprednisone. So one question here was, in the study, when was the steroid treatment initiated with respect to the time after infection? I think that's a very practical question.
It is a very practical question. I'd love to know. I don't. It doesn't say, as it doesn't say the dose either, which is really not helpful. So what do? We're actually in a sort of chat room of people interested in COVID in Germany. We're at the moment trying to figure out what sort of parameters you need to determine what sort of treatment you should give the patient. So when do you start immunosuppressive therapy? When is too early and when is too late? And I think IL-6 might actually play a role as a start point. Now we need to start with with immunosuppressive therapy. I think in Italy, most hospitalized patients, so those who are ill enough to have to be in the hospital, get steroids. That's another approach. We don't do that, but so they should be a little more ill for us to start steroids. It's a very good question, and we're trying to find out.
Thank you. Here now, 2 questions around continuing trials and what regulatory agencies are doing. And of course, you are not the right person to speak for them, but you can give us a clinician view on these questions. So here is a question that says, my understanding is as long as the benefit-risk ratio for clinical trials is favorable, agencies will not put trials on temporary hold, correct? So what is your experience in running trials in your cancer department?
I think I'm on mute.
No, we can hear you well.
Okay, there's a little. No, actually, in my experience is excellent. It's wonderful. So trials are still ongoing. We're actually initiating trials, and we can recruit. And people have been very cooperative and very, very good. Now that is Germany, and that's sort of my personal experience. And again, Germany is probably not representative in the sense that it is not the real hotspot where everything doesn't work anymore. But
yeah, people say we are 2 to 3 weeks behind Italy, and yeah. So that may be a huge difference. So the next question is here, currently vast majority of authorities do request that all protocol deviations be handled as urgent safety measures. Patients be reconsented for switching modalities to follow up, resulting in huge workload for all parties. Is there a way to publish a resolution for more pragmatism and to simplify paperwork on ongoing? I think you said that in your presentation as well, but I understand this question is going towards, you know, with the groups that you've been working to set up guidelines and probably others who are represented here. Would you be willing to carry that further and begin a dialogue with regulatory agencies and industry?
And there is, from what I understand, there is a dialogue, or there are groups, study groups, starting that dialogue to actually achieve exactly that. And I think we will bring that forward, and I think we will put it onto the agenda because it is very important.
Thank you very much. Please submit more questions. I think we have answered all of those that you've sent us, but please send more if you want to. I would like to summarize just in very few sentences, and not the totality of what you presented, but regarding clinical trials. So first, we know very little about the prognosis of COVID-19 diseased cancer patients, but there is indication that it's rather severe. You quoted the 20% mortality rate, and that is probably quite likely. So this is something that has to be considered also for people who are conducting clinical trials. On the other side, you've clearly showed an algorithm that emphasizes the importance of controlling the tumor in these disease. And I think when a sponsor makes decision on continuing a clinical trial, such an algorithm has to be included. But it is very clear that probably every treatment will have major procedural deviations in terms of visits being switched to video visits, you know, less important examinations like physical examinations or so on, not done or done at a different place like blood controls, and safety visits done by telemedicine contact, which are all attempting to keep the patient safe. So we should find a way of establishing that in clinical trials in a way that is good. But you are not arguing for a general stop of clinical trials. And you have shown us the complex field where we are in. But but it's also that it's possible to manage patients in these situations. So I think that's about all we can say, but please let us know if you have additional questions. And Marie, the last word goes to you.
Oh, well, I'm honored to have the last word, and I really thank you for your attention and for all these questions. And I'd just like to ask you all to keep the spirit up, because I think that's necessary. And I think that we can do well.
Yeah, we just got 2 more questions. I'm sorry. But as we still have time, let's look at them. So the first question is, are cellular therapy and T-cell engager trials in Europe on hold? Are there talks about that? And of course, here the problem is the CRS and the need for ICU treatment. I think it's similar to the transplant situation. So please tell us a little bit about that.
Yeah, that is covered in the EVMT recommendation as well. And I think with the CAR T cells, at the moment they're still ongoing, at least the ones I know, and the one, so we do it. But here, it must be said that the whole issue about that you have to foresee whether you still have the ICU availability in a week's or 2 weeks' time. That is obviously difficult, and here you might find situations where it is safer to not do it.
Yeah.
And here I could even see that that there could be a rationale that somebody decides to put a trial on hold in a country because it just can't recruit for a couple of months.
Thank you. More questions coming. People don't want to let you go. When do you think the first clinical trials result will arrive? I suppose this is on treatments for COVID-19. In your opinions, will these results be solid or with a low quality due to the emergency situation?
Well, the first results have arrived, as I just showed you that randomized trial.
Yeah.
And as I said, they're low quality. So I think we need more time and we need more multinational trials. And I'm not sure they'll be arriving very quickly, quite frankly. I think they're still recruiting and results are still consolidating. So I think we will be in that situation for a while yet to come.
You mean a while means later than May, June?
Yeah, something like that.
Something like that. Okay. Next question, please.
No, things are going so fast in that field. So you have new suggestions coming out sort of almost every day. So 2 months is actually long in that.
Yeah, I know. So last question so far is about the use of antibodies from patients who have recovered, so convalescent patients. How advanced is this technique? How safe and efficient? And how can it be applied to cancer patients?
I don't know. I don't think we know how it can be applied and how safe it is and so on. But I know that it is being worked on very hard, and lots of people are trying to do that and put that into place as quickly as possible. It's not available for lots of people yet, but it is being worked on, and I think possibly that might be one of the things which will come sooner than consolidated randomized trial.
Very good. Okay. Thank you again very much, Marie, and for all of the attendees, thank you very much for staying with us at such a late hour. If you want to look at parts of the presentation, you will find the recording tomorrow on the website of the CDDF, cddf.org. Thank you very much. Have a good night and stay safe. Bye-bye.
Bye-bye.